Good morning. Good morning. Time for the second plenary session, Searching for Consciousness. We have three very interesting talks on different aspects of searching for and detecting consciousness in first coma and vegetative states, then during sleepwalking, and then finally during anesthesia. So it's my pleasure to introduce our first speaker, who is Mélanie Boly, MD, PhD. She's a neurologist, a medical doctor. She's worked with really all the big names in coma research, Adrian Owen, Stephen Loews, now Giulio Tononi. She's technically currently the postdoc researcher at the Belgian National Fund of Scientific Research and neurologist, well, you're finished training now. And as I said, she is currently working with Giulio Tononi in Wisconsin. She's done a number of very interesting and important works in detecting awareness during coma and the neurobiology of coma. So please welcome Mélanie Boly.
Thank you very much. It's working. First, I want to thank the organizer for inviting me. It's a great pleasure to be here. So what I'll do, actually, Stephen Loews is also talking tomorrow, and as we work 10 years together, there's some parts of work we share. So I won't present everything. The focus of my talk today will be some kind of general introduction to neural quality of consciousness in vegetative states and doing also some parallels with sleep and anesthesia. So I'm a neurologist in training, a clinician. And as clinicians, we define consciousness, so clinically, by two main components. The first one is wakefulness, defined by eye opening, and the other one is awareness per se. And usually these two components go together, they're correlated. So for example, during sleep, when your wakefulness decreases, when your arousal decreases, your awareness will decrease too. Same phenomenon during anesthesia or coma. Vegetative state is a particular clinical entity because the patients have the eyes open but show no signs of awareness. Actually, vegetative state is not the only state where there is a dissociation like that. You can find such a dissociation also during somnambulism or in some seizures. Minimally conscious state is defined by, actually, they are very difficult to differentiate these patients from vegetative state patients at the bedside, but they are defined by the presence of non-reflexive behaviors. So for example, a response to command or some emotional reactions to stimuli. So these patients show non-reflexive or purposeful behavior, but they are unable to communicate. And then locked-in syndrome is not a disorder of consciousness, but these patients are fully aware, but unable to communicate their consciousness. So they are part of the differential diagnosis, but they are fully conscious. The problem we have with these patients is actually diagnosis at the bedside is very difficult. And if you don't use the appropriate scale, you have as much as 40% of misdiagnosis. So it's very difficult to make the difference between these patients. So in the last few years, and Stephen will talk more about that, there has been some progress in trying to detect consciousness in patients that are clinically vegetative or in minimally conscious state by trying to bypass this clinical examination and use functional neuroimaging. So for example, you ask the patient, imagine playing tennis, and you look if in the functional MRI, there's a brain activation of motor areas, for example. These techniques are really useful. The problem is they work only in a minority of patients. And if you have a negative result, then you're stuck. You cannot say anything about the state of consciousness of the patient. Maybe the patient didn't want to respond. Maybe he doesn't understand language. You have so many reasons why you cannot interpret a negative result in these kind of paradigms as the absence of consciousness. So then you're a bit stuck, and you want maybe still to have some information about general brain function and ability for consciousness in these patients. So if you don't want to use a response to command, then actually you switch to another approach, which is called passive paradigms. And as we say, actually at the individual level, we don't really know if the patient is not responsive clinically, if he's conscious or not. So what we do is obtaining different measures of brain function in these patients, and then comparing them to brain function in other states such as sleep, anesthesia, epilepsy, trying to find actually some general principles that can differentiate when you're aware and when you're unconscious. So at the end of the day, when you use this kind of passive paradigms, you end up trying to find some reliable neural correlates of consciousness and trying to find some generating mechanism for like brain ability to generate conscious perception in not only vegetative state, but the other states, okay? So that's kind of the approach I will talk about here. And so just something to mention that actually, when we use this kind of approach, we are talking about neural correlates of the level of consciousness. So in sleep, anesthesia, and coma. And it's very complementary, but it's kind of a different approach than studying the neural correlates of consciousness in healthy volunteers. The question is different. And there are other differences, but there are two main I want to underline here. So the question here is there any kind of perception? It's like a potential. Is the ability to perceive anything there? While in healthy volunteers, the subjects are aware anyway, but you're looking if they perceive like one particular content consciously or not. It's a kind of different question. And also, importantly, the correlates described in the literature are different in a way that in healthy volunteers, usually when you don't perceive something, the brain activity will be smaller than when you perceive something consciously. And actually, what I will try to show you here is that in disorders of consciousness, the level of activity is actually not sufficient. You also need another criteria, which is the differentiation of brain activity. And so using a paradigm that you use in healthy volunteers to detect consciousness or not to patients is a bit tricky. It's kind of different things. So what I'll talk about here is actually these two dimensions I just cited. So I will show you different kind of connectivity studies and show you that there are two main things that you can find as a difference between a state of full awareness and then when patients are unconscious during anesthesia, coma, sleep. And that's either you have a breakdown of connectivity or you have a loss of differentiation of brain activity. So I'll talk about three different approaches to study connectivity in the brain. And that would be first functional connectivity studies and then affective connectivity. So perturbational approach using transcranial imaging stimulation or external stimuli. These techniques, again, provide different kind of information and are very complementary. So the first studies we performed on functional connectivity in vegetative state patients were using resting state functional MRI. So just before that, we were looking at metabolism. So using PET scan, for example. And when you look at these metabolic studies, a common finding in patients in vegetative state is that there will be a widespread decrease of metabolism, not in all the brain, but in this network that you see there in red. Yeah? So a widespread frontovital network, both on the midline and on the lateral side. And actually, there's increasing evidence that this widespread frontovital network can be divided in several entities. So the first one would be on the left, simplifying very much again, some areas, mainly on the midline, which are actually areas of the default network, and people have involved default network in awareness of self, self-referential processing, memory, some like more related to self-perception. And then the areas more on the lateral side, there in red, are actually typically involved in awareness of the environment, so consciously detecting stimuli. So, well, I'll show some studies about processing of external stimuli. That's kind of a way also to study that dimension. But studying default network function in patients in vegetative state that cannot communicate is quite tricky. And actually, so we were very interested in these functional MRI studies where you can actually looking at correlations between the signal in these regions and study the connectivity like that without requiring collaboration of the patients. And so we looked at if this resting state functional MRI connectivity was a good marker of consciousness in patients in vegetative state. And it is. Actually, there is, when you look at functional connectivity in the default network, a very good correlation between the connectivity virtually in all the key nodes of the network and in the thalamus too, and the level of consciousness of patients. So this seems to work indeed. And then it's the same in anesthesia, actually. As I said, we like to compare to anesthesia or sleep to see what's happening. And in anesthesia here in the propofol, you have 4 different conditions. You have wakefulness, sedation, unconsciousness recovery. And you see that the more you go deep in sedation, the more your connectivity in the network will decrease. And then it's actually recovering when you recover consciousness. And it's not only true for the default network, but also for the lateral frontoparietal cortices. Same story, thalamocortical connectivity in these frontoparietal networks correlate to consciousness, with consciousness. It's not the case for lower level networks. So in visual or auditory networks, the connectivity is preserved independently of the level of sedation. And even in complete unconsciousness, when you completely lose response to command of subjects under propofol, you will have preserved thalamocortical connectivity in these networks. In sleep, it's a bit different in a way that total brain connectivity is, that's a recent study we performed where we really quantified the integration, the connectivity in the brain. And it doesn't seem that the total brain connectivity really decreases, but there is a reorganization in independent modules. So there's an increased brain modularity. It's a bit different still. There's a breakdown of the general global brain network in some more independent parts. Okay, so indeed this seems to work. If you look at functional connectivity using resting state fMRI, you have a good correlation between the level of connectivity, the strength of connectivity in frontoparietal cortices, not in lower level cortices, but in frontoparietal cortices, you have a good correlation between the strength of connectivity and the level of consciousness. The thing is, functional MRI, resting state functional MRI, is a signal that we don't really know. There's some kind of debates on the functional significance. That's one thing. Though now it's more accepted to be really linked to neural activity. And the second thing is, when you look only at correlations, you're not really sure that it's a product of direct causal interactions between the areas. If you actually stimulate directly an area and then you look where the signal propagates in the brain, then you're closer to causal interactions in the brain. And that's what is called effective connectivity, or what you can do actually using what we call perturbational approach. One example here is kind of the royal example, is transcranial magnetic stimulation, TMS. So you stimulate a part of the brain, you induce some current there, and then you record with electroencephalography how it propagates. And there you really look at causal connectivity in the brain. So that's kind of a good check to see if indeed connectivity is decreased in these states. And so the first study that was performed actually using TMS-EEG in disorders of consciousness was during sleep by Marcello Massimini and Tononi in 2005. And what they did is, so here you see actually the result of source reconstruction of the brain activity induced by TMS. And you see that in wakefulness it's spreading to all the brain, and then it's complex. Actually, you have, if you look at the self-reconstructed signal of different areas, you will see that the different areas do different things. So the signal is moving across the cortex, and it's like complex and connected. During sleep, actually, the response will be very focal. You have a breakdown of connectivity, and it's stereotypical. And then we wanted to confirm that also during anesthesia or coma. Is it also the case? So we used TMS-EEG in collaboration with them. And there are now a few studies showing that. For example, here is an example of patient in vegetative state, then recovering consciousness. And you see that during vegetative state, the response is much more focal than when the patient recovers. Same story during anesthesia. There's a study in midazolam that is published. We've done also that during propofol, and also importantly during ketamine, which is a very different mechanism. And in all these states, you have a breakdown of connectivity assessed by TMS-EEG. So that's pretty good, because it's indeed showing to us that there seems to be a good correlation between consciousness and brain connectivity. Well, clinically, the thing is, TMS-EEG is very difficult to do in patients. So we wanted to check also if you can have the same kind of information with another perturbational approach, which is actually using external stimuli. When you use external stimuli, you're also doing some kind of change in the brain, and you can look at causal propagation of the activity. And actually, so that's also like a valid perturbational approach. Though you don't directly target the cortex, you do causal perturbation in brain activity, and then you can look at effective connectivity changes like that. Actually, responses to external stimuli, we use that since quite a while in patients in vegetative state and minimally conscious state. That is, for example, a PET scan study, where we look at activation in the brain in response to clicks, to very simple auditory stimuli. And what you can see here in yellow, is the activation in healthy volunteers. You have primary cortex and also associative auditory cortices. In vegetative state patients, at the group level, you have only activation of the primary cortex, but it doesn't spread more. Minimally conscious state patients here in green, they activate more, not only the primary, but also the associative cortices. And if you look at the functional connectivity between the auditory cortex and the rest of the brain, you will see that patients in minimally conscious state, they have much better the connectivity is preserved between auditory cortices and then some also frontoparietal regions that I said to you we think are important for conscious perception. So that's very encouraging. The only thing is, this is PET scan and this is at the group level. But when you look at in individual patients, the story is more complex. Actually, some individual patients will activate more than the primary cortex. Even in some patients that are vegetative, like here, these two examples here, in response to strong stimuli like the own name, you can have activation of associative auditory cortices. And what we do usually to interpret this kind of data is a framework a bit like Stanislas Dehaene uses for healthy volunteers, saying, okay, if you activate the primary cortex only, it's unlikely you're conscious. If you activate the associative cortices, where it's not so much frontoparietal, so maybe you're not conscious anyway. What you need to be conscious is actually maybe our criteria should be activation of frontoparietal cortices. That could be working. So that's what we thought for a long time, and then there were some new studies coming, and here again is an example in healthy volunteers, but showing that you can activate the frontal cortex subliminally. And then we have now some other examples during anesthesia. Here, for example, it's a volunteer where you present the own name, again, a strong stimulus during wakefulness, and then under clinical loss of consciousness under propofol, no response to command, and no report after of any perception. So in wakefulness, that's the kind of network that is activated for this volunteer. And then here is during propofol. I think it's kind of a good example to show you that, well, even when you're unconscious, you can have some kind of frontoparietal activation. This is not a sufficient criteria to really distinguish at the individual level someone that is conscious or not. So, well, we thought about what could be left, yeah? What could be like the critical bottleneck. And then the hypothesis was, okay, maybe you need activation of the specialist cortices, and then you need the activation of frontoparietal cortices, granted. And actually, at the group level, it's really true. You see less activity in frontoparietal cortices. But maybe what is really limited, like what is really the bottleneck, like the common phenomenon to everything, is that not only you need activation to go to frontoparietal cortices, but also you need to go back. So some kind of backward connectivity. So that's what we thought, okay, maybe we'll try to test that. And so actually there are some new techniques now to analyze, for example, evoked potential that were developed by the team of Carl Friston in London. It's called dynamic causal modeling. What you do there is actually create a mathematical model, and you see like a realistic one, biologically informed. And you try to see what kind of neuronal architecture could create the type of signal you observe. And so you can really decompose, for example, for auditory stimuli, you say, okay, I need my primary auditory cortices, the temporal cortices, and then the frontal cortex, and then I can measure connectivity going forward and backward and see if there is a change between conditions or between patients and controls, yeah? And so they've done that in healthy volunteers, and they've done also, in particular, an interesting study in healthy volunteers showing that to explain the short latency evoked potential, so the very short lasting signal you have when you present a sound in the electroencephalogram. Actually, the activity of forward connections were enough. But then, when you look at longer latencies, like several hundreds of milliseconds, then the backward connections are really needed to explain the kind of activity you see. So there seems to be, if you summarize all that, that I just said, that frontoparietal activation, granted, is important. And when we see that at a group level, it seems to be very important as a general principle, but maybe not sufficient as a criteria to distinguish consciousness at the individual level. And then, as I said to you, maybe we thought what is left is a critical bottleneck, maybe in the backward connectivity from frontoparietal to specialized cortices. And then it's kind of nice, there is this interesting property that backward connectivity seems to be involved in long latency components. So maybe we can check also in patients if the long latency component can differentiate different levels of consciousness, right? So that's what we did, using now, again, like evoked potential, switching from fMRI to EEG, because you have a better temporal resolution to look at these forward versus backward processes, right? And so here it's a mismatch negativity with tones of different frequencies. So it's, for example, TD, TD, and the first tone is deviant. So when you change the frequency, the first time you present a tone of a different frequency, it's the deviant. And then when you repeat it several times, it becomes a standard. But that paradigm is nice because at the end of the day, you compare deviant and standard that have the same physical properties. And so it's kind of nicely matched between conditions. And then here's the kind of signal you record at one electrode, and you see there is a difference in potential there. And then it has been very much studied with the kind of architecture I showed you before. You need some kind of network with auditory cortices, but also frontal cortex to generate that signal, and frontal and backward connections. So with these kind of tools, now we go to patients and see what's happening. And so the first thing is to look at the scalp level. What I was saying to you before, is there relationship between long latency component amplitude and the level of consciousness? And it seems that there is. So here you have like the scalp topography, and here the propagation in time. In healthy volunteers, you see that there is widespread response, and then it's going until 400 milliseconds. In vegetative state, you find nothing after 100 milliseconds, and it's very localized. Minimally conscious state patients show a response that is going again until 400 milliseconds too. And when you look for an effect of the level of consciousness, you will see indeed that it's in the amplitude of the long latency connections that you can find that. So it's kind of promising. You see that indeed there seems to be a link between, in this paradigm, between the long latency components and the level of consciousness. But then what we really wanted to see is what's happening at the network level, right? So quantify the connectivity in the different connections of the network and see if there is a difference between controls and patients. And what we found is actually that where you can find a difference is not in the lower level cortices, but it's indeed, as we thought, in the backward connectivity between frontal cortex and the lower level cortices. So if you want to, so this is preserved in controls and in minimally conscious state, but this is impaired in patients in vegetative state. If you want to rephrase it differently, what we think is actually that even in patients in vegetative state, you have associative cortices that are involved, and then it's going, and at the group level, actually we see also that in patients in vegetative state, frontal cortex is involved. But what seems to be impaired is the backward connection from the frontal to the temporal cortices. And actually we've done another recent study in anesthesia, using again dynamic causal modeling, which is also in favor of this specific preferential role of backward connectivity and the level of consciousness. Here is two areas from the default network. So you have the medial prefrontal cortex and precuneus. And we looked at connectivity during actually resting state EEG here, during propofol anesthesia versus normal wakefulness. And when you look at what kind of network can generate the EEG signal for these conditions, you see that actually when you compare, this is a comparison compared so this is connectivity in the network as compared to wakefulness. And you see that for sedation, when people are still conscious, you don't find a difference. But the backward connective from frontal to parietal cortex is impaired when you lose consciousness. So this is quite fitting well together, saying there might be a link between backward connectivity function and consciousness. So what I showed you, if you want to summarize now, is that when you look in coma or anesthesia or sleep, there seems to be a good correlation between the strength of connectivity, being functional or effective connectivity, in frontoparietal cortices and the level of consciousness. And this is true for functional MRI, for TMS-EEG. And then if you look at response to stimuli, we can also maybe think that there is a preferential role, a preferential importance of backward connections in the network. So you could think, oh, cool, now it's solved, yeah? Consciousness is linked to connectivity, and when connectivity is decreased, you're less conscious, and when connectivity is preserved, you're conscious. But actually, as I said, we want a general mechanism for the different states like anesthesia, coma, epilepsy, we want to find something that is true in different states so that we can come back to patients with that criteria, because patients are quite different from the other states. So then you want to look not only in coma, anesthesia, and sleep, but also in the other conditions. And this is quite informative. So, okay, that's what I said before. If you look in coma, vegetative state, anesthesia, you have a good correlation. When connectivity decreases, consciousness decreases. And you can say, so it's maybe when you're less conscious, your brain functions less. But think about epilepsy. Actually, in some cases, like generalized tonic-clonic seizures, when you measure brain metabolism, you have actually an increase in metabolism, not a decrease, an increase in frontoparietal cortex, exactly the same than before. Okay? So there is an increase in metabolism. And when you look at connectivity, as far as we can know, the evidence is saying for now that you have some cases where when you lose consciousness, like here is a comparison between seizures where you don't lose consciousness, that are in white, and seizures where you lose consciousness, and you look at connectivity between different regions in intracranial recordings, and you see that actually when you lose consciousness, there's increased connectivity everywhere between thalamus and precuneus, because precuneus and temporal cortex is kind of everywhere in the network. So then you cannot really say anymore that decreased connectivity equals decreased consciousness as a general rule, because sometimes you can have increased connectivity and then you lose consciousness anyway. And then the hypothesis is maybe you need something else than connectivity. Maybe in these kind of cases where in epileptic seizures, like the connectivity is everywhere, then you have a loss of differentiation of brain activity. Everybody's just doing the same job, right? So that's kind of the working hypothesis for now. But there's a lot of work needed in epilepsy to check that, right? But then we can still look again in coma and anesthesia and sleep, and actually we can see this loss of brain activity differentiation in the previous studies we've done too. So if you look, for example, here is in TMS-EEG. TMS-EEG is perfect for that. You have really like a sharp spike, and then you look at how the brain activity functions. This is an example of a patient in vegetative state. So stimulating in frontal or parietal regions, and you see actually here the source reconstructed response, okay? So in this patient, you see like a very local response, but then also when you look at the traces of what the regions are doing, everybody's doing the same job, okay? It's like the same phenomenon everywhere in the brain. When the patient transitions to minimally conscious state, this is a very different story. So not only the response spreads much more, but also now there is a recovery also of the differentiation of brain activity. Like you see, all the areas are doing something different now. And it's of course the case when they emerge from a minimally conscious state. There's like more connectivity, but also very strikingly, this is like very, very differentiated and complex, and this is like one single phenomenon, okay? So there seems to be in vegetative state too, and it's not only the only patient, we have many more like that, a loss of differentiation of brain activity on top of the loss of connectivity. This is another example in anesthesia, using another property of TMS-EEG responses, which is that when you stimulate in the back of the brain, it's kind of as if you were resetting all the local oscillators. You actually uncover the natural frequency of the area. So when you stimulate in occipital cortex, typically you will have like a beautiful alpha response. And then when you stimulate in parietal cortex, they have like a Journal of Neuroscience paper showing that. You have, when you stimulate in parietal, you will have some beta response. And in frontal, you have some like gamma response. And here is just an example of global mean field power, but you see indeed that in normal wakefulness, when you stimulate there, it's slower, and then it's going faster and faster, especially in that kind of shortly after the stimulation, okay? And in anesthesia, this is completely lost. So in propofol, whatever you stimulate, it will be very localized, but also it will be the same shape of the response. It's like very stereotypical. So this is examples where you have decreased connectivity in response to stimulation and also decrease of differentiation. But there are also some other studies, in particular with intracranial stimulation or in animals, where actually when you compare the strengths, it's a bit the same story than before. If you compare the strength of the response in anesthesia compared to wakefulness, you will have a stronger response to stimulation. So in our criteria, you will have stronger effective connectivity in this case. But the difference is, again, that even if the signal is propagating a lot in the brain, in anesthesia, everybody is doing the same job. While in wakefulness, so here is like yeah, so you see here, this is parietal, occipital, and frontal, the 3 different traces of the response of the areas. In wakefulness, everybody's doing something different. In anesthesia, it's very stereotypical, and you have a lot of differentiation. Yeah, so actually, this is also showing you that even for response to external stimuli, or to TMS-EEG, if you really want to be specific on what is differentiation, like more conservative and reliable on what is differentiating a response during unconsciousness with a response during normal consciousness, you need not only the extent of propagation of stimuli, but also really to look at the differentiation of brain activity. So both are necessary. And yeah, just to mention, maybe we think that in sleep anesthesia, why we have that kind of stereotypical behavior is due to the presence of bistable dynamics, some kind of all-on response of the neurons, and that is marked in the EEG by the presence of slow waves, for example. And we did some studies showing that indeed in propofol and in sleep, it's a very similar thing. You have slow waves that really behave in a lot of ways in a very similar manner. In coma, it's not so known, but there are some indications that it might be also some likely phenomenon in a lot of patients. For example, if you look at the bispectral index, which is also looking a lot at the delta power in the EEG, there seems to be like a correlation with the level of consciousness in patients, but it's not really known. But we think that maybe the explanation for this kind of stereotypical behavior during unconsciousness in case of sleep and anesthesia is likely the presence of bistable dynamics. So I come to the conclusion now. Yeah. So if you want to summarize what I said before, I hope I could show you that you can find 2 different things, one or the other, when you lose consciousness. The first thing is you have a good correlation usually between the level of consciousness and the strength of brain connectivity. So if brain connectivity decreases too much, then it's likely your brain won't be able to generate conscious perception. At the same time, connectivity can be preserved. So, and then you cannot say if the subject is conscious or not. You need something more. You need at least to check for the differentiation of brain activity. And then if you have these 2 criteria together, again, our working hypothesis would be that you have reasonable chances then to be able to differentiate brain activity during consciousness or in unconscious conditions. So, yeah, so how to go forward now? I mean, Stephen will talk better than me about that. But what we kind of need to do is to compare the different techniques together and to obtain some normative data. So I showed you like functional connectivity, TMS-EEG, external stimuli, all show some kind of correlation between, you can find some markers of the level of consciousness in all the techniques. We have to check at the individual patient level which one is a better predictor of the clinical state and also like of the prognosis. And then kind of also trying to better understand what are the precise mechanisms. Combining different techniques is really nice for that. And well, the modeling approach like dynamic causal modeling or computational modeling in general help us also understand, because we know more and more about general principles of brain function. So if we can use all that knowledge to better understand what's happening also in the lesion brain, it can be very useful. As I said, there's still some work to be done to really have a better characterization of the neural correlates of consciousness in the different states. So not only in coma vegetative state, also in anesthesia, sleep. But there is a lot lacking, actually. Somnambulism or epilepsy, we don't know so much. And we need to know more if we want to really find some general principles of that. And at the end of the day, when you do that, you kind of take a step back from the data. And this kind of idea of finding general principles of mechanism leading to conscious perception, it's kind of taking a theoretical approach already. So there is a lot of interest actually from my side and other people to try to think about what could be the mechanism in the data and build some coherent theoretical approach. But the thing is, for now, all theories of consciousness, they are really, really at the beginning. And we need to be more precise and to bridge them to the brain and try to generate some predictions that we can test and go further like that to be able to maybe help us build a coherent diagnostic framework. And if you do that, actually, you kind of switch from like just checking the brain activity and see what is working, what we call exploratory correlates of consciousness to more explanatory ones. Try to find some correlates which are actually linked to the mechanism by which the brain is generating perception. So that's kind of the hope that one day we'll be able to do that. And I'd just like to finish by saying this. Maybe there is a reason why these frontoparietal cortices, we find them all the time more impaired when patients are unconscious, being in sleep anesthesia. Even in epilepsy, if you have an increase in metabolism, you have some kind of abnormal thing going on there, but it's always in frontoparietal cortices. And maybe the reason is that you have some evidence now that there's a hierarchy of brain connectivity. Some areas in the brain are more central or more connected than others. Like here, it's a functional resting state functional MRI study in healthy volunteers, or here, using anatomy, diffusion tensor imaging, you will find that these frontoparietal regions, exactly the same that we find impaired in consciousness, are actually the highly connected hubs of brain connectivity. It kind of makes sense that if you impair the function of big hubs of brain connectivity, you will have massive consequences on brain function in general, and especially some functions that likely require some integrated behavior of the whole brain, such as generating consciousness. So that's it, and of course, like the studies I showed are the results of a massive teamwork, especially the team in Liège, wonderful team in Liège, and our collaborators in the world. I want to thank Stephen also for like his support, his long-term support, and I want to thank you for your attention.
Let's stay here. We'll just take a few questions. Thank you, Mélanie. We have time for a few questions. Let me ask the first one. I've always been confused what is meant by cerebral integration. At the cellular level, dendrites in cell body receive and integrate inputs to an output for firing. But at the cerebral level, are you referring to the back to front activity, or is something else meant by that?
Well, I think likely both forward and backward are important. And then it's kind of not really clear at what spatial scale you should look for consciousness, right? Right. At the same time, in the brain imaging approach, we take the kind of approach where we think maybe looking at the system at the really like global large-scale level is relevant. And we find some correlates at that scale. But I agree with you, there is no like real ground truth or consensus at what scale you should look now. But
what do they mean by integration? Cerebral integration?
Well, what I mean in these kind of studies is what we can measure by connectivity, being causal interactions. And if you can, between brain areas or parts of the brain, and kind of if you can measure them with functional imaging, the spatial scale you're looking at is actually the population level, more than the single neuron level. This doesn't mean this is a ground truth, but actually looking at the population level, we have a good correlation between causal interactions and consciousness.
Over there.
Hi. Some really nice takes on it, but there seems to be three aspects to whenever we do these kind of studies. And one is the idea of consciousness, the generation of the experience. Two is the ability to report, and three is the ability to remember, so memory consolidation. So the ability to report you talked about right at the beginning, and there's obviously locked-in syndrome, and people are unable, and now I think a lot of people, excuse the pun, are waking up to the idea that we have to sort of consider this, and this is a terrible thing when people are locked in. Clinicians, often were dismissive, I think. But the third one is actually the memory consolidation is, I think, less considered, and it may undermine the entire field. And what I mean by that is, imagine that these sort of other parts of the brain, which are definitely lighting up in your studies, maybe less so, but you've admitted that you can't correlate necessarily activity to consciousness, epilepsy being the paradigm case, maybe. So what if these other parts of the brain are conscious, fully experiential, but we're not consolidating memories? So there's the possibility of a terrible, maybe it's not as terrible as remembering, but since we're basing the whole science on the ability to report, or the person who's awake, what's happening if people are undergoing surgery or under conditions where these other parts of the brain are experiencing pain, maybe other things that are fully conscious, but we have no way to access them. How do we begin to even consider that or deal with that possibility?
So the question about memory versus consciousness is actually a difficult one. And it's not only in coma, it's also in anesthesia. I'm sure Mashour is like even more suited than me to answer to that question. I would say from my point of view, it's unlikely it's only memory that would be impaired in these patients because, again, we see that widespread frontoparietal network dysfunction in them. And in patients who have only an impairment in memory, like normal subject amnestic patients, actually most people still consider them as conscious, so you don't need memory for consciousness neither. But still it's a very difficult question. Right. Because indeed we're like largely based on report, and same question sometimes people ask during sleep. Okay, if you don't, because we say consciousness is what disappears during dreamless sleep. But then when you wake up, do you don't remember or not? Actually, we take the assumption that first, as a clinician, you have any way to study and to find something. You know, you have like to try to find a solution. Second is, from my point of view, I think it's not only that is happening in these kind of situations.
As an anesthesiologist, let me just say we're faced with that question all the time. How do we know our patients are not awake, experienced, and just don't remember? And because we can't prove consciousness one way or the other, we can't rule it out. However, as George will tell us, when patients get light under anesthesia, there's all kinds of arousal and autonomic signs that we can detect. So I can say pretty certainly that our patients are not generally awake and just don't remember. One more question over there, then we got to move on.
As a general comment, this is a great talk. It's a kind of a tour de force, so much so that I'd like to hear it again in slow motion. Are your slides going to be available after this, or do you have a particular review paper that you think summarizes all this very well?
You can give me your email, I can send them to you, for example. Or we'll see, we can put them on the Coma Science Group website. All the papers we have are actually on Stephen's website. But I can also give you the slides if you want. Yeah.
Right. Thank you.
One more quick one over here.
Yeah, I have a very short question. Since we were talking about the precise definition of terms that we use, and Stu had a question about cerebral integration. What do you understand when you say connectivity? Are you actually suggesting that those networks are directly connected neurons? If you show a blockbuster, then suddenly all the TVs show up. They are not connected whatsoever.
So there are different point of views from people on that question. And it's, again, as I said, there is no definite answer to that. There are some, for example, if you talk to Carl Friston about that kind of scale, he would say that likely the relevant scale for brain integration for us to look at for cognitive neuroscience would be the population level, and that maybe the individual neurons are too small to have really an effect on whole brain function, and could be considered as some kind of a noise that could be useful in many different ways, but maybe individual neurons would be too little to really have relevance. But that's, again, a point of view. I kind of sometimes have a tendency to agree with him, but I'm still not sure neither. Though, again, as a clinician, if you want to find a marker of consciousness, it seems that functional neuroimaging can provide a lot of information. But that is a correlation, not a causation, and no. You know, like, there is a very long discussion there. Okay?
Would gap junctions count as connections, connectivity? Gap junction connections?
Oh, yeah, certainly. But here we cannot really say.
You can't rule out one type chemical.
I don't think with this data you cannot rule out anything.
Let's thank Melanie for a really wonderful talk. Okay, our next speaker is Antonio Zadra, a PhD in clinical psychology from McGill, postdoc fellow of Medical Research Council of Canada at the, I can't speak French, so we'll just say Sleep and Chronobiology Research Center in Montreal, and he will speak on sleepwalking and consciousness.
All right, so I'm going to be talking to you today about sleepwalking, somnambulism, and particularly two aspects of it. That is, what do we know about the phenomenological contents of sleepwalking episodes? And second, what are the EEG correlates that we can observe in the sleep lab when we capture episodes in the lab? So first of all, sleepwalking is a non-REM sleep parasomnia. It's typically characterized by mental disorientation, various types of motor behaviors, misperception, relative unresponsiveness to external stimuli, and variable retrograde amnesia. I put variable because in even some diagnostic texts, it says that there's a complete amnesia for the episodes, retrograde amnesia. And one thing that we'll be showing you is that that is clearly not the case, as a significant proportion of sleepwalkers are able to recall at least parts of their episodes. Now, the actual episodes themselves, which can last from anywhere from a couple of seconds to dozens of minutes, typically arise from incomplete arousals out of slow-wave sleep, and about 20% of cases out of stage 2 sleep. So it's not just limited to slow-wave sleep. The types of behaviors we can observe also vary. They vary in terms of emotional expression. The patient can be either agitated or very calm. And in terms of the motor manifestations, they can be clumsy, simple behaviors, just sitting up in bed, pointing at a wall, talking, sometimes making sense or not, fingering the bed sheets, and so on. But they can also be much more complex and elaborate, rearranging furniture, cooking, trying to eat things, getting dressed, playing a musical instrument. I'm taking for granted here that you can play while you're awake. It's not just a newfound ability in your sleep, which would be cool, but that's not the case. And sleepwalking is not a benign condition. It often leads to injury, either to the sleeper or to bed partners. Some sleepwalkers can damage furniture in their environments. One patient we saw about a few months ago, when we asked him what brought him in, he said, well, it's the third TV set that I throw to an intruder, which isn't there, and it's getting damn expensive. So there's different reasons they can come in, but the point being, this is not necessarily just a benign, sort of amusing condition. And so that's what brings most people to the clinic, is either they've injured themselves or injured others. However, relatively little is known about the mental contents that accompany these episodes. In terms of also what do we know about what's happening in the brain during episodes, there's early studies done in the 60s, primarily in a small group of children, found that the EEG recordings during the episodes were characterized by a combination of alpha, theta, and some delta frequencies, but never any evidence of clear wakefulness during the episodes. In '98, Schenk and his colleagues in Minnesota conducted a systematic review of over 250 behavioral, non-behavioral arousals out of slow-wave sleep in 38 adults that either had injurious sleepwalking or sleep terrors. And basically what they were able to outline were 3 post-arousal EEG patterns that characterized the first 10 seconds of episodes. Pattern 1 shows a diffuse rhythmic synchronous delta activity, so 4 hertz or less on the tracings. Second pattern, diffuse and irregular moderate to high voltage delta and theta activity, intermixed with some faster frequencies. And the third pattern was prominent alpha and beta activity. However, these patterns have never been examined by another group other than the one in Minnesota, and they've never been assessed in terms of also different forms of event complexity, or do they also occur in events that arise out of stage 2 sleep. So what I'm presenting to you today then are 2 complementary studies, if you want. One touching on the phenomenological aspects of sleepwalking, and second, looking at the distribution of these EEG patterns with respect to episodes that we've collected in the lab. So turning to the phenomenological aspects, I'm going to present you findings from clinical cases that we've collected in our lab at the Sleep Disorder Center. An ongoing study where all the sleepwalkers that come to our lab complete an elaborate questionnaire that looks at their history, precipitating factors, and so on. But there's a whole section dealing with various phenomenological aspects of their episodes, and I'll be presenting to you some of our findings on that. And finally, I'll show you some recent episodes we've collected in our laboratory and look at what kind of sleep mentation these patients are able to report in the morning following these episodes. So first, a few clinical cases. The first one on the top left is a woman who was found by her bed partner. She's scratching at the walls of her bedroom, and she's tearing off all of the wallpaper, not because it's horrible, but because she's hearing children on the other side, and they are screaming for help. There are no children on the other side of the wall. This is just a hallucinatory process, but this is the content of her episode. The one with the dog looking out of the bathtub, an episode from a 28-year-old male who, during his episodes, in quotation marks, wakes up. His wife also wakes up. he does have a dog, and his dog is lying, sleeping quietly on his bed. He grabs the dog by the neck, immediately gets up, goes to the washroom, turns on the water, takes the shower head, and rinses the dog. Why? Well, because during his episode, the dog, which he saw correctly, but was on fire. And so he was actually trying to extinguish the fire on the dog. The bottom left was not fun for the dog. But at least his wife wasn't on fire, which probably would have been worse. The bottom left shot is someone who wakes up during the night, grabs the bed, his girlfriend is in it as well, and starts moving the bed away from the wall, and then starts moving the dresser away from the wall. Again, his girlfriend, not too pleased being woken up in this fashion, asks her boyfriend what's going on, and he said, we got to move all the furniture, the train is coming. And so she explained to him that they live on a third-floor apartment, and there's no trains, zero effect. He's still in a panic mode, removing all of the furniture. And then she's trying to point out, well, look, which way is the train going to be coming from? Again, zero effect. He's trying to move everything and telling her to get out of bed because she's going to be hit by the train. She does get out of bed, and she tells her boyfriend, look, if the train is coming, where are the train tracks? And so at this point, he kneels down and puts his hand on the ground, and he goes, you're right, no train tracks. So third floor apartment, zero, but no train tracks in his bedrooms. That makes him realize that maybe he's having one of his episodes and that there is no immediate danger. And the last case, one that our group published a while back, a woman wakes up screaming. She tells her husband there's an intruder in the corner of the room. The husband gets up, turns on the lights, tells her, see, there's no one there. She still maintains that the intruder is hiding. He goes to the corner of the room, says, see, no one here. She tells him maybe he went to another room. He goes, fine, I'm going to go to another room. He does that. While he's in the other room, he hears his wife scream. She jumps out of the window, falls 7 meters, about 23 feet, breaks both of her legs. We've also had someone else who jumped out of the window, fell on a steel picket fence, and the fence actually went through his legs. Luckily, he didn't die. It wasn't his spine. Again, so these are extreme cases, but it illustrates the harm potential associated with this. So what these clinical observations suggest is, one, these events are often associated with various forms of hallucinations, which aren't just visual, but can also be auditory. The sleep mentation that these patients experience contributes to how the somnambulism, the episodes themselves will unfold. And these patients are able to recall at least parts of their episodes on occasion. I mentioned that now it's been several years. All the patients who see at our clinic complete thorough assessments, but also this questionnaire that contains a fairly long section on various aspects of their episodes. So I'm presenting to you data today on the 94 most recent patients that we've seen, 43 men, 51 women, a mean age of about 33. All of them were referred by their family physician to our clinic for primary sleepwalking. The vast majority reports that their sleepwalking began during childhood or adolescence, which is a typical feature. All of them had a standard polysomnography at our lab. All met the most recent International Classification of Sleep Disorders criteria for sleepwalking. And here are some of the results on some questions, just descriptive results on what they tell us. First of all, we have 62% of our patients who tell us that they remember their episodes, at least sometimes, often, or always. Again, we're a far cry from the complete retrograde amnesia that in many texts says characterize somnambulism. The patients, over 80% say they will, at least on occasion, sometimes, often, or always remember sleep mentation, that is a mental content that accompanied their episodes. When we ask them, do you ever remember your specific behaviors that you did during episodes? Again, over half will say that at least on occasions, or often or always, they do. Do you remember perceptual elements? That is, you remember seeing things in your bedroom, like the example of before, the dog and so on, your bed partner. And again, 3/4 of the people here say, yes, I do remember perceptual elements from my actual environment that got incorporated or were part of my episode. And finally, is there an emotional content to the episodes? Again, here about 75% do report that emotions are present during the episodes, and the most commonly reported ones are fear, panic, confusion, anger, frustration, helplessness. Of course, as you'll notice that positive emotions such as joy do not figure here. Finally, as I mentioned, we've also been, maybe I didn't mention it, we've also been investigating episodes in the laboratory. We've also developed diagnostic techniques to induce episodes in the lab. These involve the presentation of auditory stimuli during slow-wave sleep, typically, combined with sleep deprivation, which puts pressure on slow-wave sleep, and these people, slow-wave sleep generating mechanisms are already quite fragile. But we also have many episodes that occur spontaneously in the lab. And so I'm going to show you 4 recent examples of episodes that we recorded in the lab, together with the description of the sleep mentation that the patients reported for these. This is a francophone patient. He's a new dad, and if the volume is working, you're going to hear him say, for those of you who speak French, je l'ai échappé, which means I dropped him, I dropped him. And what he will tell us later is that he, during his episode, he believes that he is sleeping with his newborn son and that he dropped him during the night. And so he's frantically trying to look for him on the side of the bed, under his pillow, and he's also thinking, my wife's going to kill me because here she lets me sleep with the newborn and I've lost him. So this is his episode.
Oh, l'échappé. Je l'ai échappé. Hey. Vite. Ah merde, elle est où? C'est de la fille, vite. Aidez-moi, s'il vous plaît. Est-ce que tu la supportes? Mais France, c'est déjà?
Well, we never complained of pain, but when you get out of bed like that and you have your electrodes pulling on your scalp because they're well tied with a collodion, that's kind of a painful condition. Here he hears a voice and he thinks there's, again, someone in his room and he's not quite sure what's going on, so he wants to get out. Here's someone who, if I can get it to work, believes that there's insects on his bed in the sleep lab, and our sleep lab is pretty clean. And he's going to be trying to kick all the bugs and mice that are on his bed away.
No. Hey! What the move? What the? Oh, shit.
And finally, the last one is an agitated episode. Resembles a lot like a sleep terror, and actually sleep terrors and agitated sleepwalking can be difficult to distinguish. You have her EEG tracing on the side, so you see there's really high amplitude delta activity. She's in stage 4 sleep. In her episode, which you're going to hear her scream, she believes she has a snake around her neck, which is strangling her. Not fun. All right, so that's a little bit for the phenomenology. Now, what do we know when we're looking at the EEG signals that accompany these events? So I'm going to present you here some summary data on 50 events that we've recorded in our lab, 35 from slow wave sleep, 15 from stage 2 sleep. EEG tracings were evaluated by a certified electroencephalographer, and they were scored according to our previously established and published criteria. We also scored each episode on a scale that exists for episode complexity that has good inter-rater reliability. Basically goes from level 1, simple behaviors, playing with the bed sheets, electrodes, wires, and so on. Person is usually confused. Type 2, more complex behaviors, sitting up in bed, resting on one's knees, trying to get out of bed. Type 3 is any event where the person succeeds in getting out of bed. Again, what we find here across all of these episodes is they can pretty much all be characterized according to 3 standard EEG patterns, not unlike what was described by Schenk and his colleagues. The first one, again, these diffuse rhythmic synchronous delta activities, less than 4 Hertz, that we see only in stage 4 and that accompany simple episodes. We have diffuse moderate to high voltage delta and theta activity intermixed with some other frequencies, alpha and beta. And the third one is prominent alpha and beta activity, at times intermixed with moderate voltage theta activity. And one thing that is of particular interest is that the delta waves usually have 75 microvolts or more, which you only see during slow wave sleep. We notice in about 50% of all episodes during slow wave sleep and 20% of the events recorded out of stage 2 sleep. In none of these 50 episodes have we found any evidence of a complete awakening. There's also patterns 2 and 3 are the only ones that accompany episodes out of stage 2 sleep. And pattern 1, the one with synchronous delta activity, usually is only seen out of slow wave sleep and accompanies simple behaviors rather than complex ones. Here's an example of where we have yellow as the episode onset. So here's an example of EEG pattern 1 in a 19-year-old male. And you can see that the delta activity is more prominent in the anterior regions. Here's an example of pattern 2 with irregular delta and theta activity in a 23-year-old woman. Now, a question that arises is, are the sleepwalkers awake or are they asleep? And another question sometimes people ask is, are they dreaming? So first of all, if we look at the behavioral manifestations during the events, most patients, not most, actually all patients have their eyes open during their episodes. And they not only are able to, with varying degrees of success, navigate in their environment, especially if it's a known environment, but they interact verbally with other persons in the room. It might not make much sense, but they can still converse with them. The sleepwalker's environment is incorporated into their episode. Their bedroom, their bed, characters, and so on. They might misinterpret things. The little red dot on the VCR might become a laser pointer, for instance, but they still are in contact with their immediate environment. For these reasons, we like to conceptualize the sleep mentation more as a form of a hallucinatory process than dreaming per se. And then in terms of the EEG, well, these EEG patterns that we see are not indicative of wakefulness, nor are they indicative of typical sleep. And so they really support an idea where there's a dissociation between cortical and motor activities. And we also see regional EEG dissociation, where you have some alpha activity in posterior regions of the brain and slow wave activity, which usually characterizes sleep, in frontal regions. We are conducting now a SPECT-based brain imaging study on sleepwalkers, both that characterize their slow wave sleep, their wakefulness, and their episodes. There is a single case study published in the literature using SPECT during a 16-year-old man's episode recorded in the laboratory that was in Lancet by Claudio Bassetti. And basically what they found was an increase of 25% in regional cerebral blood flow in the posterior cingulate and anterior cerebellum compared to slow wave sleep, which leads them to suggest that the cingulate cortex modulates the behaviors in response to emotional processes, and also decrease in regional cerebral blood flow in other areas compared to wakefulness, which is a pattern that we usually only observe in normal slow wave sleep. And so these data, the brain imaging and the EEG data, suggests to us that the brain is at least indeed asleep, or at least partially asleep during these episodes. Now, what I've hoped to have shown you is that sleepwalking should not be characterized in terms of automatic behaviors, nor by retrograde amnesias. The behaviors that many patients will display are construed by most of them as being motivated by an intrinsic sense of urgency or logic. It might not be logical while you're awake. For instance, the example of the train that's about to hit, but it does make sense to the person during the episode. And when available, these mental contents seem to be broadly consistent with the behaviors that you observe. Now, this shouldn't be taken that the mental contents of the sleep mentation precipitates the episodes, but it certainly helps drive them and influences how they unfold. And that is really of interest to us. And the same thing for the hallucinatory processes. So to conclude, I think that our results here clearly indicate that perceptual, cognitive, affective dimensions play an important role in the subjective experience of sleepwalking. We're continuing to investigate this at different levels with brain imaging, questionnaires, and clinical case reports. And our data, I didn't have time to show you our pilot spec data, but definitely our EEG data that is quite robust thus far, supports the notion that sleepwalking is a dissociative state where you have motor arousal and persistent mind sleep. And wakefulness and sleep are not a dichotomous black and white thing. There's a lot of gray zones, just like when you fall asleep, it's not you're immediately asleep, there's a transition period. And sleepwalkers have trouble going from slow wave sleep to wakefulness, and they get stuck in this gray zone where they are predisposed to have episodes. And so maybe at a future conference we can talk, I'll be able to present to you more on our brain imaging studies during actual episodes recorded in our laboratory. And I just want to thank different members of our research team which deal with the patients when they're screaming and having episodes in the lab, among other things. Thank you.
Time for a couple of questions. Can I ask, do we know for sure that they're having subjective experience? Could they be zombies, autopilot?
Well, they could be zombies and autopilots. We haven't checked that out yet because we don't have a good test for that. But when they wake up in the morning, they tell us, yeah, I remember I had an episode last night, and this is what was going through my mind. So they're lying zombies then.
Over here.
Yeah, and we don't question them in the lab. We don't question them immediately after the episodes. They typically fall back asleep, and it's only in the morning that we ask them, do you remember having an episode, and so on, unless in the extreme cases where we have to physically intervene so they don't harm themselves.
I mean, it could be implicit memory, so they might not need to lie and still be zombies, but...
Could be.
Over there.
Yes. Do any of your patients have their condition caused or exacerbated by drug and alcohol abuse?
Not alcohol abuse. Certain categories of drugs can induce somnambulism, but these are not in people who are predisposed to somnambulism. Right, people who have, there's a very strong genetic component to somnambulism, which we're also investigating. And so these people usually have been sleepwalkers since earlier mid-childhood.
Okay.
Over there. Please be brief.
Methodologically, with the EEG, about all you can pick up is cortical or maybe thalamocortical in this case. And I'm wondering, some of this recent research from Scheinen and Turku in Finland, you're seeing people jump around. Obviously, their basal ganglia and all kinds of things are involved in this. Do you think their research sheds any light on what might be going on in somnambulism?
I'm not quite sure, only because, first of all, when we're looking at the EEG, as correctly pointed out, it's a fairly gross measure and a surface measure of activity. And then I think that in sleep, there's a lot of, if you want, atypical events that can take place, and that the underlying physical substrates really vary a lot from condition to condition. And even sleepwalking is far from being a homogeneous event. Like I said, I think probably when we get more information, the very agitated episodes versus the more benign ones probably have very different underlying substrates. So it definitely helps us get a better idea maybe of what's going on, but it's probably not just one pattern, one thing.
Yeah.
My phone. You mentioned frontoparietal suppression. And I'm wondering whether that includes the dorsolateral prefrontal cortex. And my reason for asking is, assuming the answer to Stuart's question is yes, these people are having genuine experiences, this would be a test case for the higher order thought picture of consciousness, because if there's suppression of dorsolateral prefrontal cortex, that makes it less likely that they're having thoughts, but they're having conscious experiences, so that seems to be relevant.
Well, there's some pilot, in the study published, no. And again, that was a single case study that was then compared to normative data for wakefulness and slow wave sleep. And so we don't see it there. We do have pilot data.
You don't see dorsolateral prefrontal cortex suppression?
Well, not to the extent where it would be significant, where you could see it compared to the normative data. Again, this is just the study by Bassetti is a single episode, right? That's all. And so it's very hard then to start saying, is this a significant decrease or what do you see? Because you have no real comparison basis. And it's not even compared to the same 16-year-old. It's compared to normative adult data. In our own pilot data, the answer to me so far looking at it would be yes, we do see that suppression.
Yeah, thanks for your talk. I just was wondering about reality testing functions and thinking about the episode with the guy with the train tracks.
Yeah.
How he was responsive to not to being on the third floor apartments, but checking out the train tracks. If you've seen other anecdotes pointing to what kind of cues you might respond to, I can test this one. Or
it really varies, and maybe I'll end with maybe one of the more fascinating cases with someone who had a lot of sleepwalking. His wife was really interested in his episodes, and so he'd often do tests asking his wife to tell him X, Y, and so on to see what he would do. But he had one episode whereby he really thought there was a gas that was going to kill them emanating into the room, and he woke up his wife and he said, we got to get out here, there's a gas. And then he tells her, look, I know I have sleepwalking episodes. This is not one of them. We have to get out right now. And so this is really rare, but there's critical thinking going on, and so he is aware that he sometimes does these foolish things, but he must be taken seriously this time or they're going to die.
Really quick question. You're really great at measuring and recording what's going on here, but do you have anything you can offer to these people, any therapies?
Self-hypnosis is what works best for a wide variety of these patients. And now hypnosis means different things to different people. Basically, relaxation exercises with guided imagery. Usually a couple sessions, they learn it themselves, they practice it at home, works well. There's pharmacotherapy that can be helpful as well, but we try to shy away from that because there's usually a rebound effect on their episodes once the medication is stopped.
Last question over here. He was waiting, then we got to cut it off.
Yeah, so you mentioned various types of associations with people who sleepwalk. I was wondering if there's, in your questionnaire, any associations with your work or with other work about childhood environments or even maybe worldview type associations. So like people with maybe a particular worldview or with a particular childhood environment maybe are more or less likely to sleepwalk or have certain types of sleepwalking experiences, like fearful ones as opposed to different types.
No, you can have some trauma-related sleepwalking, parasomnias, but in terms of these more general things, no. Not that I'm aware of.
All right, let's thank Antonio for a fascinating talk. Thank you very much. It's my pleasure to introduce our third and final speaker in this session, who's a friend of mine and a colleague in anesthesiology. In fact, I took him down to the University of Arizona Medical Center this morning, and he gave anesthesia grand rounds to my department and gave a great talk. And so he's going to, George Mashour is MD, PhD in neuroscience from Georgetown, Fulbright Scholar for Neuroscience at the Max Delbruck Center in Berlin and University of Bonn. Completed his training in anesthesia at Mass General and Harvard and fellowship in neuroanesthesia. He's currently Director of Neuroanesthesia at University of Michigan and Vice Chair. And he's written some of the most important papers on awareness under anesthesia and is a Presidential Scholar of the American Society of Anesthesiologists. Please welcome George Mashour.
Stuart, thank you for the very kind introduction and the invitation to speak. It's a pleasure to be here. Stuart did have me up very early this morning, so I'm doing a bit of sleepwalking myself. I've been charged with talking about consciousness in the operating room, and I'm actually going to be following up on a lot of themes that Mélanie brought up. I'm going to start by identifying a translational gap in the study of consciousness in anesthesia, then discuss cortical feedback connectivity in the anesthetized state, explore potential mechanism for feedback modulation, discuss the problem of ketamine, a unique anesthetic that poses challenges both for anesthetic mechanism and anesthetic monitoring, and then summarize with some conclusions and future directions. So first, the translational gap. I think Mélanie did a great job describing some of the very exciting studies going on in consciousness and anesthesia that have happened over the past 5 years since I finished my training: fMRI, PET scanning, high-density EEG, transcranial magnetic stimulation, or combinations thereof. And while these studies are neuroscientifically rich, the technology is relatively impractical or just not feasible for taking care of surgical patients in real time in a real-world clinical setting. On the other hand, we have a number of commercially available monitors, EEG-based monitors, and this example is the bispectral index monitor, which Mélanie brought up. And they've achieved some success in terms of practicality for the operating room, but they're not really rooted in the neurobiology of consciousness. They're driven by algorithms that are empirically derived by a comparison of the awake EEG to the anesthetized EEG, rather than specifically assessing a known or a putative neural correlate of consciousness. And again, as Mélanie described, most of the ongoing studies in consciousness and anesthesia are assessing connectivity and the way that different brain regions interact. In contrast, all of our commercially available monitors tend to focus on one area of the brain, namely the frontal region. And there's a good physiologic basis for this. We know after the induction of anesthesia that there is a shift of EEG power from the back of the brain to the front of the brain, which is referred to as anteriorization or frontal predominance. But again, this is mostly a practical matter. The patient has a surgical cap on for sterility. There's a thin strip of forehead available. It's natural to place the electrodes there. It is a regrettable injustice, but unfortunately not everyone is endowed with the requisite surface area for sophisticated neurophysiologic monitoring. So at any rate, we're posed with this translational gap between that which is neuroscientifically rich but relatively impractical and that which is practical but not really rooted in the neurobiology of consciousness. And again, as Mélanie alluded to in her last slide, the task right now is to try to bring the best of both worlds together and import some of this cognitive neuroscience or science of consciousness into the operating room. This is not just an intellectual imperative, it's also a clinical imperative. Unlike the heart, the lungs, the cardiovascular system, we don't have any standard monitor for the brain in the operating room, despite the fact that the brain is arguably the target organ of general anesthesia. And for the monitors that are available, we're starting to be confronted with their significant limitations. And this was a study that Dr. Michael Avedon from Washington University and I conducted looking at intraoperative awareness in a high-risk surgical population. Now, when we simple-minded anesthesiologists use the term awareness, we're not using it quite correctly or not as you're using it. So it's referring both to experience of surgical events and also explicit episodic recall of those events. So really what we're assessing is memory of events during surgery. This was a multi-center randomized control trial in which approximately 2,900 patients had bispectral index monitoring and alerts based on certain thresholds. Another 2,900 had more traditional anesthetic concentration monitoring, again with alerts at different thresholds. And I'm not going to get into all the clinical implications, but I will just show the major findings. The primary outcome of the study was definite awareness. So that was an event that had a high probability of occurring during the surgery when the patient should have been anesthetized. You can see in the BIS group there were 7 such events. In the end-tidal anesthetic concentration group, the ETAG group, there were 2 events. A pre-specified secondary outcome was definite or possible awareness event. So a possible awareness event is something that could have happened, it's credible, but we don't have enough detail or we don't have any objective verification. In the BIS group, there were 19 such events. In the end-tidal anesthetic concentration group, 8 events. And then finally, distressing experiences of awareness. Having an acute emotional reaction to an awareness event is a predictor of subsequent post-traumatic stress disorder. There were 8 such events in the BIS group, 1 event in the end-tidal anesthetic concentration group. Now, this was a superiority trial, so we were testing the hypothesis that the BIS was superior to end-tidal anesthetic concentration. It's a one-tailed design. So what these p-values are telling you, that are almost 1, is that there's virtually no chance that bispectral index monitoring is superior to this routine metric of anesthetic dosing that was developed in the 1960s. So we really have a long way to go in terms of taking sophisticated brain monitoring into the operating room. Now, something that I've been focusing on in my clinical work and translational work, and now in my laboratory as well, is cortical feedback connectivity. And fortunately, I don't need to give you the background since Mélanie already discussed it, but there is the notion that feed-forward propagation, and this is giving an example based on the primary visual cortex, is associated with subliminal or unconscious processing, whereas feedback or top-down or reentrant or recurrent or reverberant, however you want to describe it, is more closely associated with consciousness. Again, as Mélanie brought up, the reason why I'm even jumping to this feedback or top-down connectivity is because we know, based on a number of studies, that primary sensory processing is likely preserved during general anesthesia. Anesthesia is not preventing from information from getting to the brain, nor undergoing some basic processing. This has been shown in a number of neuroimaging studies. I bring this up from Mélanie's study, where you see the primary visual and primary auditory cortices, both in the wakeful and in the unconscious state, relatively unchanged. It's also been shown for a number of electrophysiologic studies. And this is one example in rodents with visual evoked potentials by Tony Hudetz and colleagues. The early potentials are relatively unperturbed by increasing concentrations of the inhaled anesthetic desflurane, whereas the long latency potentials have a nice dose response curve. And this leads into the notion of a selective suppression of feedback connectivity during anesthesia. Again, this study comes from Tony Hudetz. It was with visual evoked potentials, and they were looking at transfer entropy in the gamma band, going from the back of the brain to the front of the brain. And these feed-forward connections are depicted in green, and feedback depicted in red. So what you can see during anesthesia is that the feed-forward connectivity persists. It's the feedback that is selectively suppressed. Now, when the animals got to a plane of surgical anesthesia, so not just anesthetic-induced unconsciousness, but you could actually perform surgery on them without responding, there was suppression of both feedback and feed-forward connectivity. So we conducted a translational study of cortical feedback inhibition in humans, testing the hypothesis that feedback connectivity is preferentially inhibited during general anesthesia in surgical patients in the operating room. And we based this on Tony's work in animals and also a preliminary study that we conducted in human volunteers that was published several years ago with EEG. We used a different technique to assess interactions, which was based on phase dynamics. And you can see the feedback connectivity in red and feed forward in blue. Now, unlike the rats that had sort of a balanced feedback and feed forward in the waking state, we saw a predominance of feedback connectivity in humans. After induction with propofol, you can see a precipitous drop in both feedback and feed-forward connectivity, but during the anesthetized state, these levels essentially return to the feed-forward baseline, suggesting that feed-forward is not mediating conscious perception. And then finally, at return of consciousness, we saw a spike in both. And then these individuals were no longer stimulated. They didn't have any pain from surgery and were likely resedated or in a state of physiologic sleep because we did not see a return to baseline, although I'll address that later. So the study that I want to describe today was with 18 surgical patients that had a graded induction with either the intravenous anesthetic propofol or the inhaled volatile anesthetic sevoflurane. We had EEG, only 8 channels, low resolution, but again, these patients are in the operating room, and our goal is try to assess the practical applications of this concept. And we used 2 measures of directional connectivity, one related to phase dynamics called the evolution map approach, which in the end didn't appear to be that robust, and also symbolic transfer entropy, which is a relative to transfer entropy, except as the name would suggest, it uses symbols rather than numbers. And this was published this past fall, and I would just want to give credit to Dr. Sung-Woo Koo, who is an anesthesiologist from Korea who did a sabbatical with me, and Dr. Unshul Lee. They were co-first authors. Unshul is a physicist who did a postdoctoral fellowship in my lab and is now a junior faculty. So what you're looking at here is the asymmetry between frontal to parietal, the feedback, and parietal to frontal, or feed forward. Values that are positive reflect feedback dominance, which is what I showed you from the prior study, and negative values reflect feed forward. This was with the evolution map approach. This is with symbolic transfer entropy. And what you can see with both measures is that the process of induction and then surgical anesthesia leads to a preferential reduction of this feedback connectivity. Now, unlike the study in volunteers, when these patients are coming out of anesthesia, they have a lot of stimulus, pain, and you can see how this tracks across the anesthetic experience. So this is the baseline conscious state during induction of anesthesia, during surgical anesthesia, the recovery process, and then when the patient actually got to the recovery room. And you can see the cartoon above to guide you in terms of the feedback dominance. The feedback connectivity is in stripe, feed forward in the solid bars. And you can see that during induction, there is a suppression of feedback connectivity. In the surgical anesthesia state, it's essentially neutralized, so there's no asymmetry. Both are reduced, much like what I described in the animals. During recovery, the feedback connectivity significantly increases. It starts to become dominant again, and then when the patient has fully recovered consciousness, it returns to this baseline level. There was a study that was published just last week. Somebody actually brought up this group from Finland, looking at emergence from anesthesia, dexmedetomidine or propofol, to support the findings that frontoparietal connectivity plays some role in conscious information processing. And they did specify the connectivity rather than the activity, which was more drug or dose related rather than state related. So, low resolution EEG, we're in this dirty environment of the operating room. Is this just phenomenology? Can we connect this with what's going on in the brain? And from my perspective as an anesthesiologist, can we start to link this to the neurochemical mechanisms of anesthesia? And that's one thing that we don't have with any of the current monitors. Nobody's actually gone into a laboratory and tried to relate what we're seeing in the OR with what's going on in the brain. So we designed, and this is an ongoing translational study of cortical feedback inhibition in rats. So we started with the preclinical data of Tony Hudetz, we went to human volunteers, we then went to surgical patients, and now we're going back to an animal model. We're using the same anesthetics, propofol and sevoflurane, again using EEG, but obviously not scalp, but rather epidural in the frontal, parietal, and occipital areas. We're using a measure of directional connectivity, symbolic transfer entropy, but we're taking advantage of this experimental situation to look at what's going on with acetylcholine in the prefrontal cortex. And just as a reminder, there are 2 places where acetylcholine is generated in the brainstem and the pedunculopontine and lateral dorsal tegmentum, and also in the basal forebrain. And you can see that this widely projects to the cortex. And acetylcholine in the prefrontal cortex is interesting because when levels of prefrontal acetylcholine change, levels of parietal acetylcholine change, and the reverse is not true. So it seems to be some sort of privileged role of the cholinergic system in the prefrontal cortex. And we also know that states of high cholinergic tone tend to be associated with consciousness, either in the waking state, environmental consciousness, or during REM sleep with dream consciousness. So now, instead of our patients, we have an animal, and you can see there is a catheter that's delivering the intravenous anesthetic propofol. We have EEG, and up here you can see the feedback in blue and feed-forward connectivity in red. Like the prior study I showed you of Tony Hudetz, these tend to track together during the awake state. And then we start the propofol infusion here, where it turns gray. And about 20 minutes later, the animal becomes unconscious, and at that point you see this drop in feedback connectivity, and then it starts to return again when the drug is discontinued, and they start to track together. And there's a lot of variance in this post-propofol recovery state. But what's also interesting is what's happening to prefrontal acetylcholine on the same time scale. And you can see the awake state after propofol is started, there's then a drop in prefrontal acetylcholine that at least correlates with this drop in feedback activity. But again, this is just correlation. So what we're doing now is trying to probe the cholinergic system pharmacologically with a number of agonists and antagonists, and this is just one example of that. So again, you have the feedback and feed-forward connectivity. They're tracking together, as we've seen before. The propofol infusion starts. The animal becomes unconscious about 20 minutes later, and you can see now the feedback and the feed-forward have separated. At that point, we microinject nicotine into the prefrontal cortex, which agonizes the acetylcholine receptor. And you see this huge spike of feedback connectivity and also feed-forward connectivity. And this may be the connection between the prefrontal and parietal cholinergic systems. And you can also see widespread electroencephalographic signs of arousal. And then the animal well, rather the connectivity returns to the separation with a suppression of feedback connectivity under the influence of propofol. We're also exploring this with sevoflurane, and these are some preliminary data, but I think this is even more compelling because in the anesthetized state, you see the feed-forward connectivity really stays at the baseline, and there's just a dramatic separation of the feedback connectivity. And interestingly, we've shown this in humans as well. Propofol tended to reduce both, whereas sevoflurane seemed to be more specific for this feedback connectivity. And just some preliminary data, looking at acetylcholine, again, you can see that little increase in connectivity, probably some disinhibition when the animal is first exposed to the sevoflurane. You see that spike in acetylcholine, and then a dramatic drop, and then a return. I think this is even more compelling because you can see that this drop in acetylcholine is not really correlating with the feed-forward connectivity, but rather feedback. So we were really encouraged by the findings in human volunteers and surgical patients and some of the connections with other studies going on in the field. But we wanted to explore something that's a persistent problem, and that's the drug ketamine. And I'm going to give you a couple minutes of anesthetic pharmacology. We lumped them together, but there are really three major groups. Group one is characterized by drugs like propofol, which tend to be strong hypnotics. They're pretty weak immobilizers, so you can still move around, and they tend to be specific for the GABA-A receptor. Other drugs in this class might be etomidate or barbiturates. Group 2 drugs, by contrast, ketamine, nitrous oxide, xenon, don't act via GABA agonism, but rather glutamatergic antagonism. These are NMDA receptor antagonists. They tend to be weaker hypnotics, very strong analgesics. And there's also an association with hallucinatory experiences, dream states, during anesthesia or subanesthetic doses. And then finally, group 3, drugs like sevoflurane, isoflurane, the potent volatile anesthetics that we use commonly. They also agonize GABA, but they have diverse molecular targets. There's some influence on NMDA receptors, potassium channels, and acetylcholine receptors. Well, ketamine always is kind of the fly in the ointment. First, when people were uncovering the molecular mechanisms of anesthesia, they realized ketamine doesn't really fit in with the group 1 and the group 3 drugs. If you take a systems neuroscience approach and look at the effects of anesthetics on sleep-wake centers, in particular the ventrolateral preoptic nucleus, which is associated with sleep, it's active during sleep, drugs like propofol, drugs like actually isoflurane, but one of these group 3 drugs, they're associated with increased CFOS activity in Vilpo. CFOS is a marker of metabolic activity. Ketamine isn't. In fact, ketamine is associated with an increase in activity in the locus ceruleus, which is the brain source of norepinephrine, which activates the cortex. There have been many studies of thalamic depression across different anesthetics. Ketamine actually increases metabolic rate. There are many studies now looking at slow waves or hypersynchrony that might block incoming information or disrupt flexible cortical-cortical communication. Well, ketamine actually increases the frequency, and it can be desynchronized. Now, you might see some studies in the basic science literature talking about ketamine slow waves. I just want to note that they often, usually always, co-administer the drug xylazine, which is an alpha-2 agonist, which is likely the generator of those slow waves. So, you know, on the level of information theory, and Mélanie alluded to this as well with a study on ketamine, I wanted to ask the question, can this do better? So we have 30 patients, again, surgical patients. We looked not just at frontoparietal interactions, but frontotemporal interactions, following up on Melanie's science article last year. And again, what we see in these patients, we see this feedback dominance in red. I don't know if you can see this thin line at about minute 5. Ketamine is starting to be infused at that point, and it gets infused over a 2-minute period. And what you can see at minute 7 is that both feed-forward and feedback connectivity start going up. Now, this isn't just random noise or random chatter, as far as we know. Symbolic transfer entropy purports to measure causal interactions between 2 signals. So looking at it this way, the initial hypothesis is not supported, although it is interesting to consider the fact that many patients under ketamine anesthetic dream or have hallucinatory states. It's also interesting from the perspective of thinking about consciousness and this proposed model in which feedback connections are mediated by NMDA receptors. We gave an NMDA antagonist and the feedback connectivity went up. Now, I don't want to make strong claims about this, but I think it's provocative and will be interesting to think about. But then when I started looking at this again, I realized they're both going up, but they're not going up to the same degree. And if you look at the asymmetry of feedback and feed-forward connectivity, it drops. Once the drug starts getting infused and during unconsciousness, there is a drop in that feedback dominance, suggesting that, relatively speaking, the feedback connectivity is inhibited, and that is consistent with what we found for propofol and sevoflurane. So really across all 3 major classes of anesthetics, we're seeing this reduction in this feedback connectivity dominance found in the waking state, which we've seen now in almost 60 humans, either volunteers or surgical patients. So to conclude, general anesthesia is a higher order phenomenon, and I'm not endorsing any philosophical theories. What I mean when I say that is, it is likely not mediated at the level of the primary sensory cortex. We find a preferential inhibition of feedback connectivity that correlates with the action of GABA-A agonists, such as propofol or sevoflurane, but perhaps on another level, the reduction of feedback feed-forward ratio or asymmetry is common to all three classes of drugs. And we have some encouraging preliminary evidence from the lab that acetylcholine in the prefrontal cortex regulates or modulates feedback connectivity during anesthesia and perhaps in the conscious state as well. We're currently going with the hypothesis that the modulation of feedback connectivity could be a neural signature of general anesthesia. And thinking about it as a monitor, I like the fact that it's rooted in the neurobiology of consciousness. It's what one might predict from that neuroscience, and it's consistently demonstrated across multiple anesthetics, multiple analytic measures, multiple species, and now also in multiple labs. Importantly, we can start to link this to a neurochemical mechanism. So we're not just looking at what's going on in the EEG in the operating room setting. We can start to connect it with some of the molecular actions and neurochemical actions of general anesthetics. And finally, I like the fact that it's consistent with other unconscious states, such as the vegetative state. So our current directions, now that we've looked at things in the surgical patients, we want to dig in more with some translational work in human volunteers with higher resolution EEG and some more sophisticated pharmacology and more diverse pharmacology. We're doing further mechanistic investigation in animal models where we're looking at multiple anesthetics and different areas of the brain and different manipulations of the cholinergic system. We're doing technical comparisons with other measures of directional connectivity. There have been 2 studies in the past 6 months published in PLOS One looking at Granger causality, which is another measure of directional connectivity. And they find that Granger causality goes up after anesthesia. And the most recent article, specifically in the frontoparietal direction, it goes up. Now, if we're just looking for a neural signature or a neural marker, well, it might be okay that one goes up and one goes down. But if we're looking at a mechanism of consciousness in anesthesia, we need to reconcile these findings, and we're starting to make some inroads as to why we might see those differences. I'm also working with a group of medical innovation fellows at the University of Michigan, and we're starting to develop a prototype for real-time monitoring of feedback and feed-forward connectivity, as well as a calculation of the ratio between the two. And we have some crude but encouraging first passes at this problem, showing real-time calculations for propofol, sevoflurane, and ketamine. And then finally, ultimately, I would hope to explore some of the implications for consciousness. I think this question of the feedback connectivity and feedback dominance in relationship to incoming sensory representation is interesting, especially given the ketamine data, that feedback connectivity is going up despite the fact that there is a loss of responsiveness and loss of what we presume to be external consciousness, even though there might be retained internal consciousness. And in terms of using anesthetics to probe consciousness, I want to give credit to Dr. Henry Beecher. He was the chairman at Mass General where I trained, although he retired the year I was born, so I never met him personally. But he published a very thoughtful article in Science in 1947 in an era where people weren't thinking about consciousness, and they certainly weren't thinking about consciousness in anesthesia. And in it, he stated, with anesthetics, we seem to have a tool for producing and holding at will and at little risk different levels of consciousness, a tool that promises to be of great help in studies of mental phenomena. And I'm very pleased to see that 65 years later, the field is starting to catch up with Beecher's vision. And with that, I would like to acknowledge my research group, in particular Dr. Unchul Lee, who is a physicist from Korea. He was a postdoc in my lab and is now a junior faculty member. He does all of the analytic work. Dr. Dinesh Pal is a sleep neurobiologist who recently completed his postdoc in my lab and is now staying on in faculty. They've been a wonderful group to work with. These are some other members of my clinical research group that have been very helpful. in terms of these large-scale awareness studies. And I'd like to acknowledge my funding sources, the University of Michigan Department of Anesthesiology. I've got a very supportive chairman, the Foundation for Anesthesia Education and Research, the American Society of Anesthesiologists, and finally, the National Institutes of Health. And with that, I'd like to thank the organizers again for the kind invitation to speak. I thank you for your attention, and I'll be happy to address any questions you might have. Thank you.
Thank you, George. So George is one of the few anesthesiologists who are following Henry Beecher in using anesthesia to probe consciousness. The other two are also at this meeting, myself and Peter Walling. Actually, there's more than three of us. Mike Alcar, yeah, I apologize. Yeah, he's been here also. Let me ask one quick question. You mentioned the real-time analysis, and that would get around the problem with the BIS and the SEDline that it's like a minute behind reality, right?
Well, hopefully. So that, you know, one important question in terms of the brain monitors, this is processed EEG, and the processing takes time. And there can often be a lag of really up to 2 minutes before the index catches up with the state. So that is definitely a technical problem that we're addressing. I think once we remove the artifact, it's actually very easy to do a fast calculation of symbolic transfer entropy given several signals. So we are hoping to bypass that problem, but that remains to be demonstrated.
Yeah, I just had a question, how you control for, all the multiple drugs people are taking now from, beta blockers, benzodiazepines, coming into surgery, they're going through caffeine, nicotine withdrawal, they're on opiates. How do you control for that and interpret data? Because we know people aren't coming in clean in the real world.
That's a great point. I mean, there's definitely polypharmacy going on with many patients. So they're either taking drugs or they're not taking drugs that they're usually taking. This is something that we just, we're doing the experiments in cleaner settings with volunteers or animals, but ultimately we really need to see what's going on with our surgical patients who come in all sorts of pharmacologic states, also sleep deprived. But at least with the data that we have right now, it's encouraging that there does seem to be a homology between what we're seeing in volunteers and the animal setting and with our surgical patients. I should also say the effects of general anesthesia are so overwhelming, nothing else really matters. So, in the past few days we've learned about the 7 levels of consciousness from Deepak Chopra. I can tell you, whatever level you're at, when you come to the operating room, you're going down. Okay? We always win the game. We always win the game. You can be shimmering luminescent stardust. You can have the most excruciating pain of your life from a major trauma. You could be tweaking out on amphetamines. We always win the game. As far as I know, it's really infallible. We can always extinguish consciousness. I don't think there's been a single case report in 165 years of the inability to induce unconsciousness. Now, what happens during the case is another matter. Yes, sir.
Yes, that was actually sort of my question. What I was going to ask was, have you ever had a patient who wanted to experience or observe a procedure, and therefore you had to administer more anesthesia to lower feedback levels?
So have we ever had patients who want to experience the surgery?
Yes.
Spinals.
Yes. So let me give you one example, a practical clinical example. Someone who's having a knee operation. They could either have a general anesthetic, or they can have a spinal anesthetic, or they can have an epidural anesthetic. And people tend to sort out into either, I don't want to hear a damn thing throughout the whole procedure, put me out and put me out now, or I really want to be awake. I'm afraid of that sense of oblivion. I really want to experience everything. Now, in terms of, when we're in the operating room, we're not really thinking about it in terms of feedback modulation, but people definitely have different opinions as to what kind of experience they want to have, and they tend to be on both sides of the fence. I don't know if that answered your question.
Not really, because for people who are administered the same amount of anesthesia with different intentions, do you notice different results?
I see. So like somebody who's coming in more anxious or whatever, could they, is there?
Or more desirable to, have more desire to remain awake or?
Yeah, that kind of subtle intentionality and how it affects anesthetic requirements has not been studied. I understand though. Yes, sir.
Would you comment on the untoward effects of in post-anesthetic recovery for patients with open heart surgery, who've had open heart surgery, the loss of memory and the...
Well, okay, so specifically with this topic, cardiac surgery is one of the high-risk cases for intraoperative awareness. In a patient who has very poor cardiac reserve, there's a concern...
No, go ahead.
There's a concern that too much anesthesia could really significantly or even fatally compromise their cardiac function. So traditionally, that's been a very high-risk group with an incidence of about 1 in 100. There are a number of other cognitive dysfunctions that can occur after cardiac surgery: delirium, postoperative cognitive dysfunction. And I can say in general, the field of anesthesiology, now that we're much safer from the cardiac and the pulmonary perspective, the big focus is the brain in terms of what some of these neurologic outcomes are.
Also pump block. After heart, there's also being on the heart-lung machine, you get may get microbubbles, so people get postoperative cognitive dysfunction from something completely separate from the anesthesia, from being on the heart-lung machine.
You can get emboli of air or particulate matter that go to your brain and essentially cause strokes.
Let me take the prerogative and ask a question or a comment. I think you gave arguments for both sides of the hot versus not debate tomorrow, in that the back-to-front activity, I think, is important for one side of that argument, as I understand it, and the prefrontal cortex for the other. And so let me ask, if you inject acetylcholine into the prefrontal cortex and more or less reverse anesthesia, does that say that prefrontal cortex is necessary for consciousness, or could that be some kind of non-specific arousal, much like just increasing the level of stimulation?
So I'm not a philosopher, so I'm not going to comment specifically on hot, although I did get my bachelor's in it. But what I will say, first of all, we didn't fully reverse the effects of anesthesia. We reversed the effects of the feedback suppression. The cortex was aroused, but the animal was not behaviorally aroused, and that's important. So we don't quite know what's going on there. It's also important because when you inject nicotine into the centromedian thalamus in an anesthetized animal, the animal will get up and start exploring the environment. Whether there's phenomenology going on, it's unclear, but they are at least aroused. But I have been thinking, you know, I read that the paper in Trends of Cognitive Science by Hak-Wen Lau and David Rosenthal, which I thought was really interesting, and interesting to consider anesthesia. We've done other studies looking at EEG and network processing and found that the frontal area, even though you have this slow wave activity that's going on, is much less susceptible to kind of disruptive network effects than the parietal cortex. And there's certain anesthetics, such as pentothal, that don't seem to suppress the frontal lobe as much as others. So I think that's an open question, but I think that using anesthetics to probe that might be fruitful.
So for the purpose of trying to sort of map what you're talking about by reducing the feedback into some sort of theory of consciousness, exactly what are you measuring in terms of feedback? Is it through the cortical basal ganglia thalamic loop, or and how does it relate to any potential mechanisms of attention, top-down attention?
So first of all, I mean, what we're measuring, you know, this is, for our surgical patients, this is scalp EEG. So now we're not looking at anything deep to the cortex, and we're not we're not identifying the source of that signal. So we're looking at a cortico-cortical interaction. Now one question arises, well, are you really looking at a causal interaction? So when you talk about transfer entropy as a measure of causality, you're assuming that there are only two signals. Could there be a third source or driver for these changes? So I was actually really encouraged when I was talking to Mélanie last night and some of the data that she showed regarding the feedback or frontoparietal suppression, that it likely is a cortico-cortical interaction, and that this measure of directional connectivity may be equivalent to the measure of effective connectivity. So that's one answer.
So what you're measuring are just sort of correlations, temporal correlations between similarity of patterns indicating which is causing which?
Yeah, I mean, you know, if you go back to some of these definitions of causality from the 1950s in physics and think about it in terms of, you know, if I have signal 1 and signal 2, and if I can predict this epoch of signal 1 better by including signal 2 than with signal 1 alone, then I can say that signal 2 is causal with respect to signal 1. So I think that's the underlying logic, and transfer entropy is rooted in information theory.
Thank you.
I once read that about 1 in 10,000 persons who have never undergone general anesthesia, excuse me, with no obvious pre-morbidity evidence, never wake up. Has there been any progress in the ability to discern who might be at risk in such a circumstance?
Yeah, so there's very, very little literature. It's so rare, but I've actually just completed, with my clinical hat on, I do research on neurologic outcomes, and we've just completed a study of postoperative coma. So some of these patients could have emerged from anesthesia and then gone into a coma, but the incidence there is 0.06%, so it's very, very low. It tends to be correlated really more with major systemic comorbidities such as liver disease or sepsis or things like that. So the incidence of somebody who has an anesthetic and for unknown reasons doesn't come out, that's more at the level of case report. We've actually had a case at the University of Michigan where a patient, it seemed like they were in status epilepticus when they came out of surgery and just never emerged and ended up dying. But very, very rare, and as a result, not well studied.
I might add that that number has improved markedly over the time I've been in anesthesia, mainly due to better monitoring, better drugs, because most of those cases were basically due to a mishap. Hypoxia, some mishap, losing the airway.
Not from screening, pre-screening, but from actual real-time monitoring.
No, it doesn't
There have
do
been
with
huge
that.
safety advances in the past 3 decades with standard monitors and more refined drugs that have less systemic side effects.
George, what happens to parietal acetylcholine levels with the reduced feedback?
It's a great question, and that's a question that we're going to explore. We haven't looked at that yet, but ultimately the experimental design is to be doing microdialysis both in the prefrontal cortex and the parietal cortex, and then for the mechanistic studies to be probing cholinergic agonism or antagonism both in the prefrontal and the parietal. Again, there have been past studies by Martin Starter's group showing that frontal acetylcholine levels will change parietal acetylcholine levels, but the reverse is not true. So we want to see, well, is there some preferential role of prefrontal acetylcholine that's controlling this feedback connectivity, but allows feed-forward connectivity to persist during unconsciousness? So great question.
There's a lot of interest here in non-local consciousness, and of interest to me was the 7 cases out of 2,800 reported cases in which people had definite memories of events, I imagine, during anesthesia. Can you report on the robustness of those memories? And B, what's your understanding of that?
So in terms of the robustness, the ones who basically end up falling out into the category of definite awareness tend to have quite robust memory, or at least vivid description with some sort of correlation. This is a very, very sketchy, subjective game. The patient's coming with a subjective report, and then some boneheaded anesthesiologist like me is trying to figure out, well, is this real? Did this actually happen? So it is quite sketchy. You know, in terms of anesthetic-mediated amnesia, it's thought to happen in structures of the medial temporal lobe, such as the hippocampus and the amygdala. That's what's been explored. You see a slowing of hippocampal theta frequency going down to about 4 hertz under the effects of multiple anesthetics. In terms of how that might connect to certain awareness events, or more underlying predispositions. It hasn't been studied in humans, but in animal models, if you mutate the alpha-5 subunit of the GABA-A receptor, you confer resistance to the amnestic effects of anesthetic drugs, but not the sedative effects.
So it's very selective.
So they can be dissociated on a molecular level. Now, whether or not these people have some sort of polymorphism that confers a resistance is unknown. Thank you very much.
Thank you, George. Thank you, everybody. George said a lot of great things, but the best was anesthesia always wins. And that is so true. Somebody on methamphetamine with a bone sticking out of their thigh, you know, we'll get them to sleep. 800 pounds, doesn't matter. We just need more and more. So thank all the speakers. I thought this was an excellent session. Thank you all. We'll reconvene in a half an hour.